Good afternoon, everyone. I'm very delighted to have Jeremy with me today. Yesterday, there was big news from your company, so I'll start with that. So Jeremy is CEO of Smarter Technologies. Yesterday, New Mountain Capital, a very well-known private equity firm, announced that it was creating a new AI-driven revenue cycle management platform out of 3 separate companies it had already acquired. One is Access Healthcare that will provide revenue cycle operations and services. Thoughtful.ai will provide revenue cycle automation, and Smarter DX will provide clinical insights powered by AI. Your customers are health systems. The combined entity is called Smarter Technologies and represents New Mountain Capital's largest investment in healthcare. You are the CEO. You were the founding chief operating officer at Devoted Health and a CTO at Athena Health. Did I miss anything?
Those are the highlights.
Okay. So why don't you start with how many providers are you representing, how many transactions you're processing, and any of the good stuff that I missed?
Sure. So the combined platforms have about $200 billion of healthcare AR that will flow through it in some shape, form, or another. I'm not saying we control all of that today, right? But so some of it might be in a distinct workflow. But it's a very large platform transactionally. And we have over 200 customers, 60 of which are health systems and hospitals, so are in the acute setting, and the balance of that business is in the ambulatory setting.
And then what's the break between urban and rural? Do you have any rural folks yet?
So this is not really from an organization size perspective. These are skewed to larger organizations. There are some health systems that make a specialty of serving smaller communities, but this is skewed towards the higher end of the market in terms of organization size. And on the ambulatory side, where Thoughtful AI got a lot of traction was with PE-backed provider organizations where, not surprisingly, the private equity sponsors were like, why is this business process so expensive? So think, multi-state operators of a specific medical specialty.
Okay. So I'm going to dispense with the softballs.
Yeah.
Several years ago, way before the AI conversation had taken over the mainstream, I interviewed Silicon Valley technologist and VC Vinod Khosla, and I asked him what technologies is he interested in investing in. His response was, I'm not interested in incremental change. Then he added, I'm not going to ever invest in a revenue cycle management company.
That's awesome.
Why is he wrong? Or is he wrong?
Why is he wrong? So let's start at maybe the 40,000-foot level, which is this is 20% of the U.S. economy. So, and that all flows through medical claims, whether those be medical or drug claims. And so 20% of GDP. I'd love to see maybe in the audience everyone raise their hand who loves their insurance company. Right? So we're at a moment of profound societal anger about healthcare is delivered in this country. And it's because, people who pay their premiums and every, biweekly paycheck have those deductions happen and forego other things in their life, have an experience that looks something like this. You go see the doctor, you've got insurance, and then maybe 3 months later, you get a bill in the mail, and it's not for your copayment, and you're confused about what's going on. It's, you're told you got to pay the whole thing, and then what you typically do is call the doctor's office, and then they're like, you need to call your insurance company. So you call your insurance company, and then it's up to the American patient to make the two sides talk to one another, right, to resolve that. We spend $950 billion a year in the administration of healthcare in this country. The administrative costs of healthcare have risen in line with healthcare inflation. And the transactional chassis that we use to adjudicate healthcare in this country was chartered and created by the Balanced Budget Act of 1997, where we came live with a series of ANSI standard transactions where for claims, for eligibility, for prior authorization, for payment, and it is now 2024 and we're running on the same transactions. They got upgraded once to accommodate ICD-10.
Right.
And so it's absurd, right? And so then you step back and you look at the macro environment that are facing healthcare providers today, where labor costs are surging. The payer market has continued to consolidate. They have woken up and their easiest payer, which used to be Medicare, Medicare is not managed care. They publish a list of what is medically necessary, and you can essentially bill Medicare with 0 denials if you know what you're doing. They woke up and half of the market is now Medicare Advantage. Medicare Advantage is managed care,
Right.
and so what hospitals and health systems have been confronting is that their easiest payer now became their hardest payer, and they're getting about 90% of the revenue yield that they used to get on their Medicare line of business, which is 20 to 30% of their business. So that essentially wipes out the margin of a health system. And so when you think about technology, so back when I was at Athena, it was quite novel building enterprise software over the internet. We didn't even have the term cloud yet. And what we were able to do was to get everyone to a certain degree of performance, where their days in AR were under control. We had learned from the network and put a rules engine in place so that a very low number of claims were getting denied. Denial rates have almost doubled in the last 5 years. Payers have invested in AI. And so what's happened in the intervening 20 years is that EHRs happened. And so we have all this connected clinical data now. And what payers are doing is they're saying, well, I need that chart to adjudicate a claim to understand if it's medically necessary. And we don't have the infrastructure to do that.
Right.
And a huge percentage of claims just get held by insurance companies asking for medical records. And then they have a whole series of AI tools that have been deployed to claw back claims that have already been paid. So they're doing like deep learning techniques, and then they're clawing back paid claims. So I guess when you add all that up, I can't think of a better use case for the application of AI than the transactional bowels of US healthcare, which it's run very inefficiently with zero satisfaction. Long answer, I apologize.
I know, it's great. The question was a little tricky too. But a lot of companies are already providing revenue cycle, right? You have Epic, Change Healthcare, R1. Does the world need another rev cycle management company?
I think the world needs one that is a lot less expensive. So health systems pay upwards of 5% of collections, 7, 8, 9, depending on the organization. Our goal would be to charge 1%, 1.5% for the work that we do, which is not a little bit less expensive, it's a lot less expensive. And what we're starting with are virtual agents that have been deployed in healthcare settings across hundreds of payer portals and billing and dozens of billing systems. We're starting with the lowest cost to operate, most scalable offshore healthcare-focused BPO, which I've been a customer of twice in my career. And we have the most skilled deep learning team in healthcare, clinicians who spun out of New York Presbyterian, who've built an engine that helps physicians in hospitals at that intersection of the adjudication of clinical data and administrative data to make sure that the documentation is correct the first time. So our cost structure is extremely low.
Okay.
And so I think and then these agents don't make mistakes, right? So I don't know if anyone here has ever been a customer of a BPO, but what they typically do is say, we'll do a 5% quality audit, and we'll guarantee you a 95% quality score. That means that an extraordinary number of mistakes are getting through, and those are those bills that I talked about, or authorizations that weren't completed before a visit. Agents follow the standard operating procedure, and when they don't know what to do, they can reason. And then we have a really large human-in-the-loop operation that can intervene on the percentage that the technology can't today solve, right? And healthcare is complicated, gazillion edge cases, and you'll need that for a long time. But preventing all those collisions for patients, I think we need a lot more of that in the healthcare system.
So you talked about virtual agents that you're arming the provider side with, and from what I understand, you're helping health systems catch up in terms of their use of technology because the payers have already done so during the pandemic. So I guess my question is, you have virtual agents on the provider side. Well, there will be virtual agents on the payer side too. And in this battle of virtual agents, what's the end result? I mean, are we just delaying the human intervention later on? Or are we actually saying that it'll reason in such a way that the payer agent will have to concede and the claims denials will reduce dramatically?
Yeah, so a couple thoughts on that. So one is, there is just an objective truth about how a claim should be paid, right? And if you look at the audit history in any sort of billing system, anyone who knows anything about medical billing can be like, ugh, that's going to be a problem. And it's probably going to unwind over the course of 3 or 4 months. And so there are reasonable reasons every so often why a claim shouldn't be paid, like the member's not eligible, for instance. And there are, the plans are tasked with something very, very difficult in our culture, which is they're really the only rationers of healthcare, right? And the employer groups are asking them to do that. But what the workflows that I'm talking about aren't really voice workflows. They're actually the work that happens in medical offices and front desks all across the country every single day about verifying a member's eligibility, filing all of the documentation to get a prior authorization, following up on outstanding AR and resolving sort of what I would call technical claim denials, posting and reconciling payments. Those are business processes that have a beginning, a middle, and an end, and a definition of what correct is, and then exception queues to handle things that are like defects in the process. And so, the payers also spend a lot of money on administration that they would like to not spend. If you follow the news, the payers aren't doing very well today, and they spend 10, 11% on the administrative cost of what to run their organizations. So I think there's a win-win here that we can ultimately arrive at.
So you, I think before, gave a number on the total cost of administrative burden. I'm wondering if there's a way to understand how much health systems pay to, basically collect revenue.
I think it's somewhere around $300 billion.
Wow. And how are you hoping as smarter technologies to affect that number?
So every hospital, every medical group monitors a metric that's called cost to collect. So what percentage of our revenue do we need to pay to conduct those administrative processes to get the dollars in the door? And I think as a society, that number should be less than a credit card processing transaction, right? Which are typically 3%, 3.5%. If you look at these aggregate dollars and you look at what our healthcare spending as a percentage of GDP, this is a problem that the minute our population stops growing, the Ponzi scheme's over in all of our social programs. And so I think driving cost to collect below the level of a credit card transaction is what we need to be doing. And that includes the work that we do and the work that customers do. I think that's the right answer for the country.
You also talked about how you are much more cost effective in terms of how much you charge. Any way to give sense to a hospital, especially a customer your size? I'm sorry, with the number of providers they have and the number of transactions that happen. Is there a way to say, okay, you save X percent with us compared to if you go to Epic or if you go to Change or whoever?
Yeah, and so what we do is also different. So, Epic is the infrastructure that the enterprise runs on. They don't do medical billing for their customers, but there's lots of other vendors in the space, who do. And, I'll give an example. In the diligence process, I found a customer who was working both with Access Healthcare and Thoughtful AI. And we got the detailed sort of P&L of their business with all of the functions of the revenue cycle broken out. And when we looked at the services that we were asked to develop statements of work for, the internal cost plus the existing vendor spend was, and they had already offshored a bunch of work, was 3.9%. And our combined price point was 1.5%.
Okay.
So orders of magnitude different.
Right, makes sense. I wanted to ask sort of a philosophical question. I mean, during the pandemic, everything was sort of kumbaya, payers and providers got along really well, and now I think we're in like rock bottom, right? Prior authorization is a major, major sticking point. You have the AMA saying that this is worse than what EHRs, how painful EHRs were. Prior auth is more painful than that. You have payers saying, well, we can't get rid of prior auth because then providers will be, overutilizing,
Yep.
And all of that. Does a technology like yours, a technology platform like yours, help in, I don't know, resetting that relationship at all, or is that too much to ask?
I think there's a couple ways to address that. So first of all, the vast majority of prior authorizations get approved. But it's a Byzantine business process to get it approved that oftentimes involves the use of a fax machine.
Right.
Certain payers have good front-end tools, many don't. And the vast majority of prior authorizations are there for like a sentinel effect. It's the payer saying to the provider, we're watching what you're doing. We know that this is medically necessary, but we want you to be thoughtful about how often you're making this order. And most of those will auto-process and get approved. And then there's this other sort of dirty secret, which is that of the ones that get denied, if the provider appeals it, they win at a very significant level.
But there's a lot of delay and frustration in the middle for patients.
And so I think so that entire process of submitting the prior authorization, whether that has to be on a portal, whether that can be done in an electronic transaction, we can do in an automated manner, right? And so the time delay, like oftentimes it takes days for providers to like fax over the medical records, right? And so if you can secure that prior authorization immediately, because it's gonna auto process most of the time, and then track like a hawk the ones that are aging, I think you can really do well in this process. And I'd say the other thing is arming the medical group or the health system with the tools to appeal every denial. Because what happens when you when you appeal a prior auth is that you automatically are entitled to a peer-to-peer conversation in a health system between the utilization management department of the payer and the physician advisor team and the health system, and you get to argue with them very, very directly. So if you can extract the clinical argument and scale up, like basically leverage the internal physician advisor team so that they can challenge more and more and more and more, that's a huge revenue gain for providers and health systems. And the same thing applies. There's this huge battle between payers and providers about whether in a visit to the hospital merits being admitted to the hospital or an observation stay. And for the health system, it's the same cost. The revenue is wildly different. And so that's why they fight about it, right? Because the health system wants to pay, or the payer wants to pay $2,000, and the minute the patient's admitted, it's like $12,000. And if those decisions come while the patient is still in the hospital. So if you appeal every single one of those, where you really truly believe the patient met criteria for admission, it is a massive boost to the bottom line of the health system, and it is a truly zero-sum game between payers and providers.
I want to open it for questions if people want to ask something to Jeremy. While he walks over to you, I'll ask one other question. This is the eternal optimist in me. We in the healthcare world, we tend to demonize payers and think that providers are taking care of us, so we kind of treat them differently. I've seen over the last few years that providers are doing not such great things as well. Recently, one of my colleagues who lives in Ohio shared an email that he received from his provider, Cleveland Clinic, and they have sent a notice to all patients saying that you're coming for your appointment. If you cannot pay your copay, we will reschedule that appointment. So you will not be seen until you have paid. I forget the email that I received. It was not from my provider, but some other provider said very clearly, what we normally do, we're human beings. We're going for an annual physical checkup, and we have, some other unrelated question. We want to ask that question to the doctor because, I'm seeing them once a year. They're not going to bill those as two separate charges. One is part of your annual screening, which is covered by the payer, and this one that you're asking in the same appointment, you can't really ask because they're going to charge you again. So I feel like we are seeing these relationships that should be strong between providers and patients becoming more and more transactional. And I feel like it's a little bit out of desperation because they're trying to get like every penny out because margins are stretched. So the optimistic person in me is hoping that someone like you will help them say, hey, you can get more revenue out of this, so why don't you leave the patients alone?
Yeah, so I think there's a lot in there. So first of all, there is a recent change over the last few years where medical debt no longer shows up on credit reports for the American consumer. So if you're a hospital where you have a meaningful book of AR that patients owe, but it's not the hospital's fault or the provider's fault how the employers design their benefit plans, where they're shifting more and more to the patient. What are you to do, right?
Yeah.
You're not allowed by law to not try to collect it.
Right.
That's criminal behavior. And so I understand what they're doing, but I think you're right. Like if you optimized other parts of the revenue cycle, could you, be a little more consumer friendly there?
Yeah.
Perhaps. But the other tool that we have as a society that I think we don't talk enough about is the fact that there is a thing called the National Physician Fee Schedule. It gets updated, I guess, quarterly, but generally annually for the major updates. And that National Physician Fee Schedule has, valued the cognitive disciplines at a level far below the sort of disciplines that involve medical procedures. And that's probably why, primary care groups are either going to concierge models where they don't have to see so many patients, or figuring out whether they need to bill separately for things that they never would have before.
Right. Go ahead.
Jeremy, thanks for kind of your overview of the RCM practice that you're running. Like, you talked about so many different areas, right? Like referral management, claim status requests, eligibility, denials, no response. Like so many areas where like money gets stuck in the revenue cycle, right? Especially as you think about automation and like agentive AI products, where do you think the lowest hanging fruit is in that healthcare rev cycle model that we could really apply automation and get big dollars back right away?
Yep, it's any workflow. So I'll distinguish it between sort of in the practice management system or the billing system, and then in the interactions with the outside world. Anything that can be done through a user who is provisioned within a payer portal to do work on behalf of a health system or a medical group should be done via a virtual agent, right? Because those portals exist to deal with the deficits of the standard ANSI transactions, where those transactions themselves don't allow for the transmission of enough information. And so those transactions are intended to be filling a form, attaching a document, hitting submit. And then you can train these agents about where to go find the data within the billing system or the EHR to go fulfill that request. I'd say within the billing system itself, there's a lot of time and money spent on simple business processes like posting payments, closing the books at the end of the month, where you've got to, someone laughed, it's like a really hard process where you got to reconcile your AR to the bank, and you want to get that done by the 7th or 8th day of the month, right? That can all be automated, right? And so I do, the area where I would say is not low-hanging fruit today is voice. And so voice is improving unbelievably quickly right now. And so state of art in this industry changes like every 6 weeks. I think that a lot of people are getting very excited about virtual agents on the phone with patients. And I would not be a trailblazer in that particular case myself. I think that the American consumer is not yet trained, and we have no idea whether they're going to expect that and that they can get excellent service through that channel. When they do, I think it's wonderful. And I think then what you could do is take offshore call centers and move them back to the US. And if you're able to handle with a virtual agent a certain amount of the volume, the math will work, right? And I think that's ultimately what consumers want. And I've seen excellent offshore call centers, and I've had experiences that have not been good. But I think ultimately getting to someone who can answer the question that you have, and you think about the raw material of healthcare, scheduling an appointment, you need to reschedule an appointment, following up on a claim or a bill, like these are stressors, right? This is not, a routine interaction like you have in the rest of your life when you try to do certain things, where it's okay if, the person wasn't so kind to you. There's a lot of emotion behind the topics that people are calling about. So that is one where I would not be the trailblazer personally.
Go ahead, Sachin.
Hi. So thank you, Jeremy. I definitely see a lot of promise for where agents can play a role. The reality, what I see, and I'm just curious how much time your systems need to be trained to really handle the amount of chaos that we have, right? So just give you one example. I manage 2 practices. We have several other practices that we work with. The challenges I see are multifold, as in if I work with an IPA that works with only 3 specific DME suppliers, then for us to get a prior auth on a CGM or some device like that is so manual, so chaotic right there, right? And the denials of claims themselves, the integration with the EHRs, because every EHR captures your claims differently, and the amount of money we spend on collecting that from reimbursements. So overall, I think the list goes on and on, right?
Yeah.
So what does it mean from your services to really deploy or even get ready to work with a practice?
Yeah, so one of the first steps that you've got to do is ground an agent in the policies and the procedures that would be used by the group to train anyone who they employ. Because in healthcare, there are some tomato decisions about, do you apply the patient payment to the last in or the oldest, or things like that. Or a uniqueness around a certain type of medical billing. So you got to ground it in that baseline understanding. And then you have to deploy it and watch what it's doing. And there's usually like a 2-month, 3-month process of working through all the edge cases where on its own, without relying on extensive compute for reasoning, you got a good baseline. And then what you do is when the agents fail, right, you allow them to reason, and then you start putting humans in the loop to evaluate whether they were making good decisions or not. And then over time, that learning engine allows the agents to do more and more and more. And these agents get deployed globally, right? So if you deploy a prior auth agent in one customer, they have the same knowledge, not of the specific client, but of all the payers, what their screens look like. They've done all the visual learning and pathways all through these systems. You know, that you just got to chip away at it, right? And it's a series. You can get up to about 60 or 70% automation, and then after that, it is like you just sort descending on the like defect type, and you ramp that up. But I think the biggest mistake people are going to make is not accepting the fact that you need people involved in the process, overseeing what the process does, and completing the things that fall out. There is no magic bullet here, but if you can automate 70% of it, that's a huge cost savings.
Sean, you get the last question.
Thanks, Arundhati. Jeremy, thanks for your presentation. I represent employers and purchasers in healthcare, and I'm excited about the possibility of your technology to substantially improve prior auth process. I'm also petrified about what your technology is going to do to medical spend. If we make it easier for hospitals that already make up more than 50% of our costs to, quote, not leave dollars on the table, how is that going to do anything other than take us from 20% of GDP to 23% of GDP? And are we better off if we make it easier for hospitals to get more money out of employers?
So, you know, I think I'll go back to an earlier point that I made, which is that there is just an essential truth about how much money should be paid. And if you get a panel together of 6 medical billing experts and you have them huddle, they will give you an answer, right? And yeah, there's murkiness in coding standards and things like that. And I think that what we have is a slow motion train wreck that prevents us from answering that fundamental question. So, you know, so what happens a lot of times is, you know, a hospital bills a claim, and because of, like, if you bill an inpatient admission and they say it's observation, they can't just pay you the observation, they pay you nothing until you rebill it. I think the goal is to get to the answer as quickly as possible and cut out all the waste, heartache, and horrible patient experience that happens in all that delayed time before point A and point B.
Hallelujah to that. My stomach's rumbling. I hope yours is.
Yeah.
Good. We're ready for lunch. Thank you
Thank
so
you.
much, Jeremy,
Yeah,
for supporting the conference as well.
thank you.